Thank you. Good evening, all our esteemed members of Maharashtra Ophthalmological Society, all our members who are joining us from across the country, also from All India Ophthalmic Society, and especially welcome to our young stars, our postgraduates who are joining us from everywhere. We know, friends, that you are the future of ophthalmology of India. Indian ophthalmology is gaining a lot of respect world over because of all the scientific work and also the clinical surgical work which is being done here. And a lot of this work is now pioneering work across the world. And you are the flag bearers of taking forward this work in the right way. We all know that postgraduate programs are integral part of Maharashtra Ophthalmic Society's scientific work. And this year, we have decided to designate 1 month for one specialty, not only for our postgraduates, but also for our members, where we are having two postgraduate programs every month on that specialty. We are having a legend of that specialty in the MOS Legend series and a webinar. So today we are extremely honored to welcome each and every one of you for this PG program in the specialty of refractive surgery. We are honored to have our panelist joining us today is Dr. Rupal Shah, who needs no introduction. She's a pioneer of smile, especially, and refractive surgery in general across the country. Uh, she will be joined by our MOS faculty, a very good friend and a very prolific cataract and refractive surgeon, Dr. Somil Kothari, who is joining us from the Bombay City Eye Clinic and Research Center. I'm sure we are going to learn a lot from both of them today. Today's session is going to be mentored by Dr. Kavita Dabade, madam, who is joining us from GMC Nagpur, and the cases will be presented by Dr. Surbi and Dr. Harsha. Today's session will be moderated by Dr. Zain, who is a very dynamic young refractive surgeon, and we are very thankful from the team MOS to our chief coordinator of the PG programs, a very dynamic, very sincere and hardworking Dr. Sumit Lahane. So I would like to now invite our Honorable President, Dr. Santosh Agarwal, sir, to please give his welcome address. Over to you, sir.
Thank you, Vardhaman. Respected seniors, my dear friends, postgraduates, greetings and good evening to one and all. I welcome you all to this unique webinar, which will throw light on the refractive surgery cases. We would tonight navigate through the refractive surgery related cases, wherein PGs would present the cases and subsequently we will face the viva questions posed by the mentors, followed by the panel discussion. I express my gratitude to the experts, panelists, moderator, scientific committee, and the audience for sparing their valuable time. I am sure we all will be enlightened with the intricacies and nuances of these diseases. I thank Sumit, Vardhaman, Aditi, and MOS Scientific Committee for curating this webinar. I also thank especially PGs for taking initiative in presenting those cases. They can put their queries in the chat box or can send to the Dr. Sumit or Dr. Jain to have interactive session. And I seek your valuable feedback also subsequently after webinars so that we can curate our next webinars in a very fruitful way. So thank you everyone and thank you for your patient listening. Over to Vardhaman, please.
Sir, your code is remaining.
Yeah, quote is there. The hallmark of successful people is that they are always stretching themselves to learn new things. Life is not a problem to be solved, but a reality to be experienced. Be fighter always. This is the quote of today.
Great,
Thank you
sir.
very much.
Thank you so much, sir. And always we look forward to learn from you and your code. They really inspire all of us, and I'm sure all the young postgraduates will be definitely inspired by them. Now, without further ado, now I would like to hand over the proceedings to both Dr. Sumit and Dr. Zain. Over to you. Thank you.
Thank you, Adaman sir, Santosh sir, Aditi ma'am and Natul sir for providing this platform to the MOS. And the PGs are doing great. They're enjoying. I do get feedback from various colleges that they are getting this exposure to present in front of such a senior faculty. We are all grateful to you. So today we have a refractive specialty, and we have our mentors who have been already introduced, Dr. Rupal Shah ma'am. I can just say about her that she is teacher of everyone present in this webinar, and almost more than 70% of the people who do refractive surgery. Ma'am has more than 30 years of experience in this field. Thank you, ma'am, and very warm welcome for you to spare your time. Dr. Soumi Kothari sir. Soumi Kothari sir is a director and consultant at Bombay ICT Institute, Mumbai. He is our go-to person, and we are grateful to him that he is available even on a single WhatsApp message and always replies to our query, anything that we ask. Welcome, Dr. Soumi sir. We have our mentor, Dr. Kavita ma'am from Nagpur GMC. I would like to say here that Nagpur GMC is only second college in Maharashtra government college which has a LASIK machine, and all thanks to the faculty who is handling the machine and who is also teaching the kids about the refractive surgery in their young age. My dear colleague, my friend Dr. Zain will be moderating the session. He himself is a very good refractive surgeon, and he will be handling the show from now on. And our today's hero, Dr. Harsha and Dr. Surbi, will be presenting their cases today. So without wasting much time, I would like to hand over to Dr. Zain, and Dr. Harsha kindly share the screen and start your presentation.
Thank you, Dr. Sumit. Yeah. So, Surbi, you will be presenting your case first, right?
Yes, sir.
Yeah. Please do share your screen. So the first presentation will be by Dr. Surbi. Yeah, you can start when you're ready.
A very good evening to all of you. Myself, Dr. Surbi Rajiv Kumar, Junior Resident from Government Medical College, Nagpur. Before beginning my case, I would like to thank all the MOS committee members for giving us opportunity and a platform for such a kind of interactive case discussion. And also, I would like to thank my teachers and my mentor for guiding us. So here I begin my case. A 28-year-old female patient resident of Nagpur presented to IOPD with chief complaint of blurring of vision in the left eye since 4 months. The patient gives a history of wearing a thick, high-powered glasses for distance since childhood, for which she underwent a surgical procedure for number correction in both her eyes 5 years ago. She reported that her vision was good after surgery and it remained stable. But since last 4 months, she is experiencing a gradual, progressive, painless diminution of vision in the left eye. There's no history of any contact lens use, no history of trauma, pain, redness, discharge, watering, or itching or frequent rubbing of the eyes, no history of photophobia, monocular diplopia, glare, or any allergy. Past medical history, no systemic illness, and ocular history, she had undergone a refractive surgery procedure 5 years ago. Personal history, normal appetite, normal bowel and bladder habit, no history of smoking or tobacco chewing. Family history, no similar complaint in the family. General examination was within normal limit. Her vitals was also normal. Systemic examination was also within normal limit. Ocular examination, facial symmetry was present. Head posture was normal. Eyebrows at the same level. And eyeball alignment was also normal in both the eyes. I would like to describe the ocular examination of the right eye first, followed by the left eye. In the right eye, the visual acuity was 6/6. She was not accepting any glasses. Lids normal in the right eye, conjunctiva clear. Cornea of the right eye, normal size, elliptical shape, regular surface, transparent with sensation present in all the quadrant. Flap was in situ with a LASIK flap edge was seen. Rest of the anterior segment of the right eye was within normal limit. In the left eye, the visual acuity was 6/18, which improved to 6/9 with -1 diopteric sphere and -3 diopteric cylinder at 160 degree. The lids and conjunctiva was normal in the left eye. In the cornea, it was normal size, elliptical shape, regular surface, transparent with sensation present in all the quadrant. Flap was in situ and a LASIK flap edge was seen. Rest of the anterior segment of the left eye was normal, and on retinoscopy in the left eye, seizuring reflex was seen. Fundus examination of both the eye was within normal limit. So based on my clinical examination and history, my provisional diagnosis of the right eye is it is within normal limit, status post LASIK surgery, and left eye a query post LASIK corneal ectasia. Thank you.
Thank you, Dr. Surbi, for your presentation. I now invite Dr. Kavita to just ask Surbi few of the questions related to her case presentation.
First of all, I would like to thank MOS and Dr. Agrawal, especially Dr. Sumit, for giving us opportunity to present in this program. Okay. Dr. Surbi, I just want to ask you, what is scissoring reflex? What do you mean by scissoring reflex? And
Dr. Surbi, just stop your screen share.
what are the causes of scissoring reflex in this patient?
Ma'am, the scissoring reflex, the optics behind scissoring reflex is the one part of the aperture is relatively myopic compared to the other half, which is hypermetropic. So due to mixed aberration, the one half of the reflex has different refractivity compared to the other half. So two band of reflex is formed, which move towards and away from the each other, like the blade of scissor. The scissoring reflex can be seen in irregular astigmatism, in keratoconus, if there's any corneal opacity or scarring, the scissoring reflexes is seen.
What are the any five types of refractive surgeries you know?
Ma'am, refractive surgery can be classified based on cornea, lens, or combined. Ma'am, in corneal refractive surgery, we have some flap-based procedure like LASIK. Then we have some LASIK and SMILE. Ma'am, then in surface ablation, we have PRK, photorefractive keratectomy. Then, ma'am, in cornea, we have intrastromal ring segment. Then, ma'am, in lens, we can have phakic intraocular lenses. And in combined procedure, we can have bioptics or trioptics.
In LASIK, do you know the variants of by the procedure by which it can be performed? LASIK?
Ma'am, in LASIK, we create a flap. In LASIK, we have
with the help of what you create the flap?
Ma'am, with the help of microkeratome or femtol laser second, we create flap.
What are the contraindications for LASIK?
Ma'am, LASIK, ma'am, it is generally not performed in age less than 18 years. If the patient is having unstable refraction, ma'am, in certain ocular pathology, LASIK is contraindicated like keratoconus, corneal dystrophies. If the patient is having severe dry eye, ma'am, other condition like if he's having herpetic keratitis, or in pregnancy and lactation, it is also not recommended. Then in glaucoma, cataract, LASIK is not done.
What is the minimum age for consideration of LASIK?
Ma'am, minimum age it is 18, more than 18.
What are the topography findings of keratoconus?
Ma'am, in keratoconus, we can see central or inferior steepening, which is represented by warm colors like red or orange. Ma'am, then there's inferior superior steepening asymmetry of more than 1.4. Then there's also asymmetric bow tie pattern with a skewed radial axis. Then keratometric values are more than 47 in topography. Then
Yeah, Dr. Kavita,
yes,
is that it? Do you have any more questions?
One more question for you, Dr. Surbi. Your patient is having ectasia. What are the various risk factors for development of ectasia post-LASIK?
Ma'am, in post-LASIK, there are certain score assessment to detect patient who can develop post-LASIK ectasia. Ma'am, certain factors, if the patient in topography, if he is having asymmetric bow tie pattern or inferior steepening or skewed radial axis, if the manifest refraction spherical equivalent is more than -8, if the patient is having a low residual stromal bed less than 300 micron, or if the corneal thickness is thin, less than 500 micron, ma'am, generally, if the flap is created using microkeratome, then the chances are more compared to femtolaser second. If intraop this deep ablation is done, then the patient with keratoconus suspect like formafrost, then he can develop post-LASIK ectasia.
Very good, Dr. Surbi. Thank you so much. Over to Dr. Zain.
Thank you, Dr. Surbi, Dr. Kavita ma'am, for that grueling Viva session. I just request now our esteemed panelists, Dr. Rupal Shah ma'am, Dr. Somil sir, to just comment about the overall case presentation and her responses for the Viva. Just remembering that refractive surgery is something that PGs are not that good at it. Yeah, so just over to you all.
Zen,
Yes, sir.
she answered beautifully. All the answers were up to the point and very perfect, precise answers. And it's very appreciative to know that as a postgraduate student, to have that much knowledge is very creditable.
Good job, Surbi.
I would agree with Soumil. I really didn't expect this level of thoroughness. So Surbi really well presented. Couple of points I would like to point out. One is, why would you not measure the intraocular pressure? I saw that you've written digitally, it felt normal. Post LASIK, you can measure intraocular pressure with applanation. So it would not be right because intraocular pressure is very important. It also erroneously may show a lower reading. Secondly, I think it's also a good idea, since you are just beginning to present, to run a spell check on the slides that you make. Because I saw a couple of mistakes, and that can be a deterrent. And it can just distract you from the main point. So just be careful about that. It's a simple suggestion, but I think it would help you in future. Other thing is that all these points that you made were absolutely relevant. But there are times when ectasia can occur even in a normally occurring looking cornea. And they can get precipitated by certain factors like hormonal changes in the body, pregnancy. Also, how would you explain only one eye having ectasia? What do you think is the course that the other eye will take? Do you think that it is going to remain normal, or what do you do with the other eye? And what would you do with this eye, the one which is showing ectasia?
Ma'am, the eye which is showing ectasia, for time being, we can prescribe patient spectacles because she was improving to 6/9. We can also suggest a contact lens. Then in serial follow-up, we should investigate her with topography to know the actual measurements. Then if there's a progression, we can consult with the cornea specialist and we can advise patient collagen cross-linking to arrest the progression. And serial follow-up should be taken for the patient.
Very nice. What about the other eye? What would you do?
Ma'am, right now she's having a good vision, 6/6, no complaint in the right eye. So for time being, we can perform topography, and if and in follow-up.
So no rubbing, and very important to maintain vitamin D levels to normal, because that definitely has a role to play. But very well presented and very well done. Congratulations.
Did you have topographies done for these patients?
Yes, sir.
You had, right?
Sir.
So can you put it up? I mean,
So actually, Somil sir, we are the topography is not part of the PG curriculum for the case presentation. That's why we have not put it for the particular case, and we want to just ask until the clinical exam is relevant. But we'll be sharing some topos later, just for the PG teaching once the case presentations are done.
Also, you should know the relevance of each point that you made. So if you asked history of rubbing of the eye, So you can be stopped and asked that why did you ask for rubbing? Why did you ask for trauma? Trauma because it was only in one eye, not in the other, right? She may have a habit of sleeping only on one side. Rubbing of the eyes, everything can predispose to ectasia, especially in a patient who is prone to keratoconus. So each history point that you made, you can be stopped and asked why you asked that thing. Is it relevant directly or indirectly?
Very true. Also, she was a 28-year-old female, and
Yes.
she developed symptoms for the past 4 months. She had done LASIK when she was 23 years old, I believe.
Yeah.
So she's of childbearing age. So again, that
Yes.
also has a role to play by the hormones inducing the ectasia during pregnancy and lactation.
Right. So, thank you for the panelists for your comments, and I think Surbi well presented. The take-home messages also, which Dr.
Very well
Rupal ma'am
presented.
said, were
Congratulations, Surbi.
yeah.
Thank you.
Okay, so I think let's move on to the next presentation by Dr. Harsha. You can start sharing your screen again. And Dr. Harsha is also a final year PG from GMC Nagpur.
Good afternoon, everyone. I'll start my screen sharing.
Yeah. Yeah, your screen is visible. You can start.
A very good afternoon. Before beginning, I would really like to thank all the MOS committee members for giving me this golden opportunity. And I would also like to thank my teachers and mentors for all the constant support that there has been. I'll begin with my case presentation. A 25-year-old female patient, resident of rural Nagpur, came to our outpatient department with chief complaint of gradual progressive diminution of vision in left eye since 2 months. She is giving history of wearing thick, high-powered glasses for distance since childhood, for which she underwent a surgical procedure for number correction in both the eyes 4 months ago. The vision was good after surgery and remained stable. But then again, since the past 2 months, she has started experiencing gradual progressive painless diminution of vision in left eye. There's no history of trauma, any contact lens use, itching or rubbing of eyes, pain, intolerance to light, double vision, or any allergy. Past medical history was not found significant. Personal and family history was also normal. In general examination, the patient was conscious, cooperative, well-oriented to time, place, and person with vitals within normal limits. The systemic examination was also normal. Coming on to the ocular examination, the facial symmetry was present, head posture was normal, eyebrows at the same level, eyeball alignment in primary case was normal. I'd like to describe the right eye first and then left. In right eye, visual acuity unaided was 6/6, not accepting glasses. Lids and conjunctiva normal. In cornea, size shape was normal with sensations present in all the quadrants. There was flap in situ with LASIK flap as seen. The rest of the right eye anterior segment details were within normal limits. Coming on to the left eye, the visual acuity unaided was 6/12, improving with pinhole to 6/9, best corrected with -1.2 diopter cylinder at 130 degrees to 6/9. The lid and conjunctiva was normal. Cornea size shape was normal. Sensation was present in all the quadrants. Flap was in situ. On slit lamp examination, a grayish-white irregular opacity of size approximately 3/4 mm connecting to the inferior flap edge, partially covering the central pupillary axis, was seen, suggestive of an epithelial ingrowth. The rest of the anterior segment details of left eye were within normal limits. Examination of both the eyes that was done with direct ophthalmoscopy confirmed on 90D lens was also within normal limits. Based on my history and clinical findings, my provisional diagnosis was both eye status post-LASIK with left eye post-LASIK epithelial ingrowth. Thank you.
Thank you, Dr. Harsha. You can stop sharing your screen. And over to you, Dr. Kavita.
Dr. Harsha, very nicely presented again. Very aptly described. How did you diagnose the epithelial ingrowth?
Ma'am, based on first of all, the history that the patient was giving, first of the refractive surgery, second on slit lamp, I could see LASIK flap edge, and then the opacities that was connecting to the inferior flap edge and covering the inferior pupillary axis. I made a provisional diagnosis of an ingrowth.
Can you tell us the post-op complications of LASIK, all the known complications?
Among the known complications of LASIK, we have most commonly flap-related complications are most commonly seen. We have flap displacement, or we have flap folds formation that could be a macrofold or a microfold. And then we have epithelial ingrowth. We can develop post-LASIK ectasia. More commonly, these patients are prone to developing dry eye because in LASIK, we are creating a flap. We are denervating the subbasal plexus of corneal innervation, so they can develop dry eye. We can have infectious keratitis, or we can have what is known as sands of Sahara, called diffuse lamellar keratitis, which is a sterile inflammatory reaction to any foreign antigen that is introduced in the interface while we are working.
What do you understand by epithelial ingrowth?
Epithelial ingrowth basically means that in the procedure that we are doing, the epithelium of cornea ingrows between the stromal surface bed that we are creating and the undersurface of the flap. That is what we are meaning by epithelial ingrowth.
What are the various risk factors for its development?
We can have preoperative risk factors or intraoperative. Preoperative risk factors would include a patient who has risk of recurrent epithelial erosions like epithelial basement membrane dystrophy or diabetic patients. Intraoperatively, if there is epithelial erosion or post flap displacement, or if the part of stroma that we are ablating is more than the size of the flap, or irregular flap size, that can also predispose to epithelial ingrowth.
What are the various ways to treat it?
In my case, like the patient is symptomatic and the growth is covering the pupillary axis, I'd like to go ahead with a flap lift and debriding the undersurface of flap and the stromal surface of the epithelium, and then repositing. We can use adjunctives like mitomycin 0.02%, or recently we've been trying to replace this by replacing and suturing the flap back.
Your patient is having minus 1.25 diopter cylinder, right? And with that,
Yes,
the
ma'am.
visual acuity is improving up to 6/9. What must be the reason why it is not improving up to 6 and why the patient is requiring cylinder?
Ma'am, basically because the kind of refractive error that is being induced due to the epithelial ingrowth is an irregular astigmatism, in the sense that the epithelial cells that are going in the undersurface of flap are creating irregular topographic elevations on surface. So instead of a smooth contour, we are getting irregular astigmatism, and we cannot address that by a simple spectacle correction. So we are not getting 6/6.
Okay, thank you, Dr. Harsha. Very nicely presented. Ma'am, Rupal ma'am, your comments, please.
I'm speechless actually. Harsha, are you a second year student, resident?
Ma'am, third year.
Have you seen any LASIK procedures?
Yes, ma'am. Online videos only.
Not a live one.
Live, I've seen only PRK in college.
And because this is quite impressive what you presented and the way you answered. It was almost complete, and it's really amazing to see that for a topic like refractive surgery also you have such in-depth knowledge, and that is really nice to know. Because you don't really get exposure to any refractive surgeries when you are a PG. And I know that when I was a PG, I had a short note on excimer laser, and now my whole life is lasers. So it can change from one point to another. Couple of things. The word that you were looking for was interface. So when the
Yes, ma'am.
epithelium goes in the interface, that's called an epithelial ingrowth. Secondly, besides mitomycin C, you could also use alcohol. For how long would you use it? What should be the exposure time?
Ma'am, mitomycin exposure time is normally 30 seconds that I've seen it do.
And one important factor for epithelial ingrowth is also repeated blade
Flap.
use. So if you keep using your blade for microkeratome blade too many times, since the microkeratome blade has to go through an intact epithelium when it creates a flap to begin with, and it is also oscillating at a very high frequency. So if it has become blunt because of overuse, it is going to not be able to go through that easily. And therefore, at the edge of the epithelium, it is oscillating very high with high frequency. So chances of taking epithelial cells in becomes much higher. Also, the edges then don't remain any more sharp, but ragged. And that's one of the commonest cause in India for epithelial ingrowth.
Ma'am, may I ask you one question? Rupal ma'am,
Sure.
what is your experience about having epithelial ingrowth as far as femtosecond laser assisted LASIK is concerned or blade assisted?
I've been using femtosecond laser since 2008. So it's almost 15 years plus now. And I have not seen a single case of epithelial ingrowth. So I think it's because the flap edge is so well opposed and it gets almost locked in. Plus, you are not going through an intact epithelium ever because the side cut is also done with a femtosecond laser. So I think that epithelial ingrowth chances are much, much less as compared to a microkeratome in a femtoflap. This is one thing that femtoflaps really score over microkeratome flaps.
That is true that the risk of epithelial ingrowth is seen higher in microkeratome flaps as compared to femtoflaps. Also, the risk increases with repeated LASIK enhancements. We call it LASIK enhancements, retreatments. So that is another risk factor for epithelial ingrowths. So that is one factor which you have missed out in answering. But overall, very good presentation and very precise answers again.
Saumil sir, would you want to ask any questions to Dr. Harsha or point out anything related to her presentation?
So there are, do you know the types of there are two types of epithelial ingrowths. One which may be just peripheral spot-like opacities which don't really interfere with the vision. And the second one is the type which you have more confluent, more central, and interfering with the vision because of exactly what you said, not only physically obstructing the visual pathway, but also the topographic elevations and irregularities that it causes also may be just paracentral epithelial ingrowth. It may not be in the pupillary center, but it still may cause distortion of the vision. So the former, that is just isolated spots, don't necessarily need any treatment. They just need to be observed. But the one which you have, central, confluent, affecting the vision, it definitely needs treatment in the form of precisely what you answered. And a lift of the flap, washing out of the epithelium, and along with the wash, many people, what they do is also they remove a skirt of epithelium 1 to 2 millimeters around the flap edge. That is because when they are repositing the flap back, it allows that 1 day of the flap being adhered before the epithelium grows over. So that allows them time to prevent further recurrence of epithelial ingrowth.
Also, it's very important to follow up these patients, especially in the first couple of months after the surgery, after the wash, because they have tendency for recurrence. It has to be observed very, very carefully.
So, since we are on this topic, Saumil sir and Rupal ma'am, I just wanted to ask you all. I mean, Rupal ma'am, you've not seen since 15 years, but
No,
would
only
you
for
also
with
remove
femto, with
for femto?
microgadolabs
Okay,
I have seen.
okay. So would you remove a skirt of epithelial tissue at the side when
I
you?
don't normally do that,
Okay,
but I know that people do it for precisely the reason why Saumil. But when I'm doing an enhancement, I make sure that I'm not disturbing the epithelium when I'm entering. And that I think prevents epithelial ingrowth from happening. But if you are not sure of your technique and if you feel that you have disturbed the epithelium, it's a good idea to just remove a little skirt of epithelium for the reasons Saumil pointed out.
thank you so much, Rupal ma'am, Saumil sir, for discussing this case. And Harsha, you answered really well. Is Vardhaman sir here?
Also, Harsha, IOP.
Yes.
Please measure IOPs.
Yeah. So I think the
IOP
take home.
and refractive surgery are quite integral. IOP has to be measured.
Yes, you must measure it. And applanation. No other way.
So I think we've got some good pointers for the two case presentations. Well done. And so we'll take this meeting forward. Dr. Atul sir, you have something to point out? Yeah.
I just want to ask Madam Rupal ma'am, in some cases, in spite of being everything is normal, where the PTA or the topographic picture is normal, but still in the post-operative phase or after some years, we face this ectasia problems, post-classic ectasia. So, what did you think that the single or the for a common comprehensive ophthalmologist who is doing LASIK also, what he should look for so that he should avoid such type of scenario after doing LASIK in the long term? Anything?
Dr. Atul, this is a very important question. See, in refractive surgery, we are treating patients who come very early, and ectasia or frank keratoconus can also start a little late in life. So it may be that this person is going to have keratoconus and you accelerated it by doing a refractive surgery. That's one thing. Second thing is that, as Saumil pointed out, some hormonal changes in the body which can make the collagen tissue weaker. So if you've already weakened a cornea, that will act much more and you can develop an ectasia. Sometimes it's chronic allergies leading to eye rubbing, vitamin D deficiencies. There are so many factors playing a role. But if you are going to do a refractive surgery, the point is to make sure that the time when you are going to do refractive surgery, at that particular moment, you should be 100% sure that you are not dealing with any form fristic keratoconus and that you are not surpassing any limits, whatever procedure you are doing, right? But some of the cases you can't just avoid because they are keratoconus which are just presenting themselves at the time they normally present. And you have been, you've already operated on these patients, so you become a part
of the
bad
luck of that ophthalmologist only. Nothing.
Having said that, I would say that the percentage of ectasia is not that high. So don't be afraid of ectasia. Just be careful to evaluate the patients very, very carefully. And only having equipments is not what is going to matter. Simple thing like dilating and looking for a scissor reflex also goes a long way in determining these form fristic keratoconus. So don't not learn retinoscopy. That is going to be the base of a refractive surgery setup.
Thank you, ma'am.
Actually, the thing is, with regards to ectasia, we are still learning. We don't know everything about ectasia any which way. We are far from it. Initially, when LASIK started, there was nothing like ectasia. There was no entity at all. Then we started looking into the corneal thickness. Then we started looking further into the corneal shape. So we are discovering things on the way in the whole journey of the whole LASIK and refractive surgery journey. We are discovering new and new things. For today's scenario, as far as ectasia is concerned, a topography, a well done topography should be enough. But we all know that even if the topography is so called normal, there are certain eyes which progress onto ectasia because of factors we don't know yet. That's why we have instruments like the Corvus or initially the ORA, which all measure the corneal rigidity, what is a hysteresis. But again, that's just another factor which we are taking into account for ectasia. There are so many unknown things which are happening which we don't know yet. So not that we can predict ectasia in every case. We having done enough number of cases, any surgeon who has done enough number of cases will have ectasia on their hands, and that is a given. But at the same time, as of today, topography is the gold standard, and not only topography, tomography rather is the gold standard, and which should be done in every case to at least predict if ectasia is there or not. That way.
Thank you, Somil sir. So on that note, we'll just see some topographies, and we'll just have some teaching pearls from you all for the postgraduates. I'll just share my screen now. Yeah. So is my screen visible?
Yes.
Yes, sir.
Okay. Somil sir, we'll start with you, and then we'll go to Rupal ma'am. So, generally as spotters, the postgraduates are kept, a pentacam, and they are asked to report certain things. They should know, what are the important things to pick up from this map. So this map is there in front. Can you just in a very simple way highlight what are the things their eyes should go to over here, and what are the red flags, so-called red flags?
Sure. So then this is a 4 quad map, as we say, and the quad map shows 4 different maps in one screen or one printout. So the 4 maps which are here are the sagittal curvature, the front curvature, the corneal thickness, which is the bottom left, the top right and the bottom right are elevation maps, front and back respectively. So, and on the left side are all numerical values of various. You can see that the front of the cornea K1, K2, back of the cornea K1, K2 is there. The pachymetry and its values are there, and overall the anterior chamber depth and everything is there. So that is now one important part which is missing from this frame is the age and the sex, gender of the patient. That is also to be noted while you're reading the map, right?
Right.
Having said that, now starting from the say you can see that on the top left, the sagittal curvature, the front curvature is showing a slight asymmetric pattern, right? The keratometries are well within normal limits. That's 44, 45, 43. It's not a very flat nor a steep cornea, but it does show a subtle asymmetry. Now, that asymmetry is very important to be picked up, right? On the bottom left, correspondingly, there is a corneal thinning. You can see that the centermost points are around 470, 474 microns. And if you see the left side pachymetry numerical values, you can see that the thinnest point is 469 microns, right? So that is another point to be just kept in mind. So you have on the top left, you have asymmetry. On the bottom left, you have a low pachymetry. The top right, that is the front elevation map, is essentially normal. There is no change which I can see in the top map. Although you can see that there is a yellow spot with a +6 written on it, I wouldn't consider that as a significant point at this uh, isolated point of view. I would not consider that as significant. But on the bottom right, if you see that in the same place, there is +16. That is the back elevation, there is +16. And on this, now considering everything together, you have the back elevation, which is +16. The front elevation in the same area is +6. That means that it is elevated in that area, in that zone. Also, the sagittal curvature, that is the top left, is showing asymmetry with a slight steepening in that area. and the corneal thickness is less. So viewing this whole thing together, that is where you have these red flags of asymmetry, low pachymetry, and elevation. All three which are there, pointing to a quite a contraindication for any LASIK procedure or corneal blaze procedures is something which you need to avoid in this patient if it's possible.
Thank you.
Can I just add
Yes,
one
ma'am.
thing?
Yes, ma'am. Rupal, ma'am, you can just comment on
It
it.
was very well explained, Saumil. Only point is that you should also look at the quality of the map, because sometimes the quality of the map is not so good, and then you can have false positive signs. And in this case, you can see that it's very well taken map. So
Yeah.
all the things that Saumil said is actually making a total sense and guiding you towards diagnosis of early keratoconus. Yeah.
Right. So
Also,
thank you.
sorry,
Yeah,
just
yeah.
one more point to add to that. Not only the quality, but also the centration. Sometimes the eye tends to be decentered.
Yes.
The corneal apex tends to be decentered, which is not the case in this scan. It's a very beautifully taken.
Yeah, beautifully
scan.
taken scan.
So, which is perfect. That is where we can actually validate all our arguments regarding the red flags.
Right. So just to summarize the pointers, I think for PGs, look at the age and gender, as Saumil sir said. Look at the quality of the scan. The top left is the sagittal curvature. Look at whether it is symmetric or no. The bottom left is pachymetry. Look at the thinnest point, where exactly the thinnest point is. In this case, it is coinciding with the area of steepening. The top right and the bottom right are elevation maps. And Saumil sir and Rupal ma'am, for Pentacam, any cutoff values for elevation maps for the PGs to remember, where you can say that it is to be considered as a red flag?
Saumil?
Yeah, so essentially, I would not in isolation consider it, but again, I would tend to stress look at the pattern more. That's more important. But posterior values of nearing plus 18 and anterior values nearing plus 12 or 11 will be what I will be a red flag in my mind. Again, these are not absolute numbers. That doesn't mean 17 is okay, 18 is not. But it needs to be seen in an overall picture.
Okay, thank you. So quickly now to the panelists, suppose this was a patient coming for refractive surgery opinion. Would LASIK be an option for this patient?
No.
No. Okay. Would PRK be an
Definitely.
option for this patient?
No.
Okay. Saumil sir, what about
PRK
you?
also is a subtractive
Right.
procedure, and therefore, in form fristic keratoconus, that cornea needs to be left alone, observed, and if necessary, if there is a progression, a corneal collagen cross-linking. At that particular time, the flattening may take care of some part of the refractive error. But in general, if there is no change, and if this is the pattern, you should leave that cornea alone.
Thank you, ma'am. Saumil sir, that's the same for you?
For this particular question, I would need to know the refractive error of the patient.
Okay. So for you, it's like you are not labeling it anything right now, but you need more information. And
No. I am labeling, like Dr. Rupal said, I am labeling it as keratoconus, right?
Okay.
But one of the treatments for keratoconus is cross-linking. I mean, that has to be done. But whether cross-linking is to be done alone, or can we at the same time try to correct the refractive error by doing a topography-guided PRK plus cross-linking, is what I want to now decipher in this patient. Which of the options that I would look at?
Okay, great.
So age is also important.
Age is important. So ma'am,
it has come to you at 40 years of age, then natural collagen cross-linking would start.
Absolutely.
And then you would not want to touch this cornea. So you look for progression, you look for refractive error, you look for the other eye, how progressive is the condition there, and then decide overall whether this is a fit thing to go on the cornea.
Are they also, how are they tolerating spectacles? How are they tolerating regular contact lenses? Are
And
they
whether there is any progression.
and the progression? Absolutely.
Thank you so much. So just we'll go to see one more map at this stage, which will be slightly more tricky, and just get an opinion on that as well. Okay, so here we have the age. Okay, so we've got a 34-year-old male. This is the refraction. This is the topography. So now we have 4 options. This patient has come for refractive surgery opinion. We reject, we wait and observe, we do a PRK, or we do a LASIK smile. So Rupal ma'am and Somil sir, this time we'll start with Rupal ma'am. Can you please comment on this?
Is this a dilated refraction? So cycloplegic refraction?
No, ma'am, it's non-cycloplegic.
So cycloplegic refraction is first thing that I would do.
Okay.
Secondly, what about the other eye? Is the other eye showing the same type of picture?
Yeah, so let us say the other eye is showing the same type of picture. We don't have the map of the other eye, but let's assume it's showing the same type of picture.
And you have 6/5 vision, right?
Yes.
I would wait and observe, and then wait for 6 months at least, see if there is any change, and then do a surface ablation. I would not want to, if there is no change, if the refraction remains the same, everything remains the same, I may consider a surface ablation. Ideally, with such small power, 34-year-old male, I may just tell him to wear glasses and not take chances.
Okay. And ma'am, what would you want to label this as of now? Suppose considering the other eye has a similar kind of
Suspect, I would say.
Okay. Okay. Somil sir.
Yeah, I have a slightly different opinion possibly. So here you can see one is it's a 34-year-old, right?
Yeah.
So if something was to already happen, it probably would have happened by now. What I mean by that is the ectasia or keratoconus would have possibly set in by now if it was really an aggressive keratoconus. But this doesn't seem to be that. That is one. Although on the top left, you can note that there is a superior inferior asymmetry. Correct?
Right.
But
yes.
At the same time, on the bottom left map, the corneal thickness map, there is no corresponding thinning of the cornea. In fact, it is it's getting steeper. I mean, it's getting thicker as we normally would see in a normal cornea. Now, on the top right, the elevation is quite okay. But on the bottom right, that is a back elevation, it is showing 2 separate zones of sort of elevated points. You can see it's not really a bottom elevation, but it's a bottom left and bottom right elevation, which you can see plus 21, 23. And like these peripheral elevation points don't necessarily point out to having a weak cornea as such. So in my opinion, this not necessarily is a keratoconus. Now, very important for postgraduates when you have I mean, I don't think you'll get such a map in your exam, but you can always tell the examiner that I would prefer to do an epithelial mapping of this eye, so that many times epithelial irregularities can lead to such a pattern of superior inferior asymmetry, with the corneal thickness being quite normal and other parameters being normal. So that is what
also, if you have a ptosis, it can create such a appearance because it will press on the cornea above and cause such a map to occur. So that's also one more thing that you should take into account.
Absolutely. So I wouldn't like to label this as anything currently. I would rather just look at the epithelial map and then see if this is just an epithelial abnormality or not. And with regards to the options
if it's a cone, what will you see on the epithelium?
With the charger, please.
Yeah, Harsha.
Yes, ma'am.
Yeah, the PGs can
If you
answer
take
the
an
question.
epithelial map and this is, say, a cone developing, what would you see on the epithelial map?
I could see a Fleischer's ring probably if it's a cone developing.
No, on the epithelial map, what would be the pattern? Over the cone, will it be thicker, thinner than the surrounding area?
Thinner, but the thinning will correspond to the steepening.
So you see a thinner epithelium over the cone, right? So it appears like a donut, like an island.
So, Zain, with regards to the options, I would see also if this patient is quite keen I would not really, I'm not sure whether this is the right cylinder which he has, which needs to be treated at this cylinder. Again, if it's just an epithelial thing, we may not really, it may be a variable cylinder which is created by our irregular epithelium. So I would be treating this patient first with lubricants and steroids and watching over time of how the refractive error changes or it doesn't that way.
So I think both the panelists are of the opinion that this patient shouldn't be treated and we should wait and observe with treatment and just study the scans. And another important pointer that's come out here is that the epithelial map is, along with topography, I think an important tool now. And thinning over the area of steepness is something that you should look for in the epithelial map.
Also, you should look for dependency on glasses when you're dealing with a patient who is going to undergo a refractive procedure. So a 34-year-old male, even uncorrected vision for this particular patient is not going to be less than 6/12 and N6 uncorrected.
True,
and binocularly, it may be going out even up to 6/9. So you have to also look at the need for a refractive surgery, especially when you are crossing the norms.
True. Thank you, ma'am. Thank you, Saumil sir. Ma'am, we have time for, I think, one more discussion. So just let's quickly talk about this last aspect, that is treating in presbyopia. So, ma'am and sir, your comments on this one case, 46-year-old female, hyper-O plus 2.5 with plus 1.75 add, no cataract, keen on getting rid of glasses. What would be your option for such a patient? Would you do distance LASIK? Would you do a monovision LASIK? Would you do a prelex? Would you do ICL, which would be for distance, or a presbyopia correcting ICL, or would you do nothing at all and wait for cataract to develop?
Can I go first?
Yes, ma'am.
Okay. Ladies first, ma'am, always, and it's just especially pretty ladies first.
So, first thing I would want to know is the K reading of this patient. Because if it's a flatter cornea, I would want to go on the surface and not otherwise. Because otherwise, the induced aberrations are going to be too much. And the tear film also, I would want to know whether it's on the side where you would expect some amount of dryness in a 46-year-old female, but it should be controllable and treatable, and she should be comfortable with just 1 or 2 lubricating eye drops during the day. So I'm assuming that it's a normal, healthy cornea with good tear film and a flatter cornea. Then I would want to do a micro monovision and not really a total monovision. Because in a hyperopic patient, you would be creating a hyperprolate cornea, which anyway gives you a little more depth of focus. So even if you can just do a small micro monovision, looking at the dominance of the eye, it would make the person independent, less dependent on glasses and not maybe totally independent. But she would be very happy because she cannot see good for distance nor for near. And here she would have very little dependency on glasses. So the profession of the patient would be important. So if somebody is a driver, maybe you don't want to do that. Somebody is a painter, maybe you don't want to do that. But I'm talking about a normal individual with normal requirements. They are very happy even at this age if they undergo a micro monovision LASIK.
Okay. And what is your cutoff for keratometry at for this sort of?
So for this particular patient, even if she's at around 44, 45, I'm fine.
Okay.
But more than that, steeper than that, I would not be too keen.
Okay.
Because we are then putting that patient right on that upper margin of steepness and aberrations.
Right. Yeah. Somil sir?
Very true. So just again for the PGs, assuming that this we are dealing with a normal case, okay, normal patient actually, with all normal parameters. Now, I hope they do know
So
what.
usually females are normal.
Yes, absolutely. That's only the males which are like all hyper. True. Agreed. So I hope they do know what is ICL and what is prelex and all these terminologies. But having said that, let's go from bottom to up. Nothing is, well, the patient is keen on getting something done. So nothing will not be the correct way to go about it. Yeah, that is one. Second is ICL. ICL or phakic IOLs are interventions which I would tend not to do for this very low refractive error patient. And also being hyperopic, I'm not sure whether the anterior chamber depth would be adequate for placing an ICL or not.
If it is, let us say it is.
Even if it is, I would prefer to do a corneal-based procedure rather than an ICL, phakic IOL. Third is prelex is quite out of the question in my mind because the patient is very young for a presbyopic lens exchange. I would only sort of consider prelex in people who are, I don't know, 55 or 60 up, right? And below that, I would not really consider presby. There are definite advantages of having the lens still, the natural lens intact in your eyes, rather than going for artificial lenses all the time. So I would not consider prelex in this particular case. Now we are talking about the first two options, which is LASIK essentially. Now LASIK can be either both the eyes corrected for distance, where she'll enjoy a very good distance visual acuity, uncorrected, but she'll have to wear glasses for near. Versus monovision, as Rupal madam said, where one eye is corrected for distance, the other eye is corrected for near. Now, I would consider seriously monovision. I agree with Rupal madam, but also I would be testing her for that. I will be, if she's already wearing contact lenses, then I would be prescribing monovision contact lenses to her to see if she can adjust to the monovision, which we are going to induce after LASIK. If she is not wearing contact lenses, I would still do the same with her spectacles. It does give a fair idea, an indication of how life would be with monovision. So having said that, if she is getting used to monovision, then that is the first choice in my mind. If not, I'll be discussing the option of at least doing a distance corrected LASIK in both the eyes with the option to wear reading glasses only.
So thank you for those comments. I think so. I think Rupal ma'am is going with a mini monovision or micro monovision, and Somil sir would want a distance LASIK, or if the patient is accepting a full monovision, would go for a full monovision. But the idea is a young patient, whether myopic or hyperopic, you don't consider prelex, you consider a laser-based procedure. Am I correct? And the keratometry
Also
has
take
to
home
be.
message is that it's not that LASIK should be done only for people who are young.
Right.
Yes.
More than
Very
40 years is not a contraindication for doing refractive surgery.
Absolutely.
Because they are the ones who are also keen on refractive surgery and are also happy patients.
True. So I have just a similar case, and this is slightly different, but the patient is 10 years older with a minus number now. Again, no cataract, keen on getting rid of glasses. So again, Rupal ma'am, Somil sir, quick comments on this situation as well.
So this time, ma'am, I'll go first.
Yes, yes.
So highly myopic, and myopes generally have the tendency to develop cataract earlier on in age rather than otherwise. So again, he's 56-year-old already with, and I just said that 55, 60-year-old, I will consider presbyopia lens exchange. That has its advantages. In the lenses nowadays, the advanced technology lenses are able to correct, have a good range of vision, are able to correct distance and intermediate or distance intermediate and near based on what lens you choose. But in general, I will still avoid a trifocal lens or a multifocal lens in this situation, being predisposed to myopic maculopathies. I would rather just go in for my choices would be a monofocal versus an extended depth of focus, an EDOF lens in this particular situation. So if the retina is clean, there is no maculopathy or degeneration. In that case, I will still prefer the EDOF lens. Otherwise, I'll go in for a monofocal lens.
Yeah, I would just like to add that if you're going to go for a prelax, what you need to also do is make sure that the OCT macula is done to know. So if you're going to be going in for any of these premium lenses, also look for any toricity required, because otherwise the whole idea of doing a refractive lens exchange would go for a toss. So what I do normally is to do an IOL master, also do a Cirrus or a Pantacan, so that in case required, if necessary, later on, you can do a small touch up on the cornea, because these patients are too keen not to wear glasses at all. So it's important that you should know whether your cornea is going to yield for that. And if necessary, put in a toric lens and look for the OCT macula to see even slight changes and ERM developing, because the contrast sensitivity after any trifocals, multifocals, and even an EDOF lens would be less than what you would get with a monofocal lens. So after clearing all this only, I would go for a prelax.
Perfect. So, ma'am, your option also would be prelax for this patient?
Yeah, in this particular case, yes.
Okay. So, yeah, I think those were some situations which I just got forward.
But this patient will not come to me. They'll go to Soumil.
Or Zen.
Thank you so much, ma'am. Thank you, Soumil sir. We've come to the end of the webinar. I'm not sure whether the office bearer, so Atul sir is here.
Yeah, I am here.
Yeah, because they had to leave for the All India meeting, I think most of them.
No, actually today also they keep the scientific committee meeting also for MOS Fund coming Sunday.
Oh.
So it's at 9 o'clock. So most of the president and the scientific committee chairman Vardhaman is not here because of that only.
Dr. Atul, can I take just half a minute? I would like to really congratulate Dr. Kavita for asking really grueling questions. I thought you completed the whole thing by asking the correct questions. And secondly, I really thoroughly enjoyed this. Please include me in your future webinars.
Thank you so much, ma'am. Thank you. Thank you, Rupal ma'am and Soumil sir. Your comments were excellent. Excellent comments. Thank you.
I am here for
you have very nicely conducted the webinar.
I am here for the official vote of thanks. But first of all, I would like to thank Rupal ma'am, because she is the one who introduced me to this refractive world. Ma'am, I don't know if you remember, we were there at your place in 2013. My first LASIK I done at your center. And she was I think she was air hostess. And so it was a thrilling experience. And after that, the journey started. So thank you very much. Thank you, Dr. Soumil. And thank you, both the presenters. It's really nice to see knowledge of refractive surgery at the third year residency.
Yes.
It's good. I mean, it's really appreciable. Because most of the time they are mainly interested in cataract. So that's still it's a thorough knowledge. It's very appreciable, commendable. Thank you. Sumit is not here, but he is the person who is conducting and who is organizing all this, arranging the show. Then you had kind of moderated the session very nicely in the absence of all MOS office bearers. Thank you very much for that. And hope to see the next PG episode. I just want to convey to all PG students and the members, do attend our PG activities. They are really interesting and they help you in exams also. And for the members, it's helpful to brush up the knowledge. Thank you very much.
Dr. Atul, can PG students from other states join?
Yes, they can. Actually, ma'am, I have made a group of a PG student. It's almost 300, 400 PG students are there, and everybody I made an admin. So I want them to add all PG who are their friends. So I think today also many of the PG students who had joined are from other states also. So I can there is no such as such no restriction for that. Only the presenters we selected from the Maharashtra.
That makes sense.
That is
Perfect. Thank you.
Thank you.
Thank you, sir. Thank you.
really interesting session. Thank you, everyone. And thank you for the presenters. You really presented very well and
Yes.
showed very thorough knowledge, depth of knowledge. Thank you.
Thank you. Thank you, sir.
Bye. Thank you, ma'am. Thank you so much, sir. Thank you.
Bye, Zain. Bye, Dr.
Bye.
Bye, Zain.
Bye.
Bye,
Bye,
sir.
ma'am. Bye.
Bye, Dr. Kavita.
Thank you.
Bye, Rupam.